Okay, now we're going to do chapter 9. Sideshow. From the current slide. Okay. Alright. We're going to do common environmental emergencies. I'm sorry, but I had to have a drink because my throat is really kind of getting like Miss Candler's, which I certainly hope I don't get. Let's go ahead and get started with our heat-related illnesses, especially since this is summertime, although it's kind of hard to tell. It's not real hot, but there are days that it's really humid and it feels really hot. So sometimes it's kind of odd that the your book says that you can actually develop a heat stroke in temperatures um, that are not all that warm. And you can also develop cold injuries, even if it feels like it would be warm enough for most people. So it just kind of depends on disease processes as to whether a lower temperature would result in heat or frostbite. So let's talk about the heat related ones first. We have heat exhaustion and we have heat stroke. Anytime you have patients who work out in the heat, you live in the South where it's hot and it's humid, you're looking for things such as heat exhaustion and heat stroke. Patients who have heat exhaustion, who say construction workers been working outside for years, but today it's been extremely hot and really humid, and he begins to feel ill. Then he comes in and complains of flu-like symptoms. So heat exhaustion is going to be a patient who's been exposed to a high heat source, such as outside temperatures, and they come in and they complain about headaches, weakness, fatigue, nausea, a low erection, orthostatic hypotension. Um, their body temperature may not be significantly elevated because it's not really an internal temperature. So the treatment, of course, is going to involve immediate termination of physical activity and put them somewhere where it's cool and give them something to drink. So that's basically how you would treat your heat exhaustions. They may be perspiring heavily and, of course, having inadequate fluid and electrolyte intake. And dehydration and hyponatremia is going to be something that's going to be going on, which is going to cause the nausea and the vomiting. So if you don't treat heat exhaustion, if they just continue on and you don't make them rest and be in a cool spot, it is going to lead to heat stroke. So heat exhaustion can lead to heat stroke quickly, and you need to hopefully that there's a community resource out there that's teaching, and I know it comes on the radio quite often about be sure you know what the temperature is, that you have fans on, cool temperature, drink plenty of fluids, trying to prevent heat exhaustion. So be aware that um, they will and may continue to um, go into heat stroke. Placing cool compresses in areas of large heat sources, such as under their arms, behind their knees, on top of their head, in their groin area. Those will help cool them off quickly, and that can be done as well. You could even spray water on themselves. Um, they don't recommend that patients drink plain water when they're trying to rehydrate during heat exhaustion. They do recommend the electrolyte balanced drinks, such as the sports drinks or um, like Propel or whatever type of sports drinks you like to drink. Okay, so again, teach them how to stay out of there. View your chart that's in your book. Chart 9.1 gives you heat-related illness prevention. Uh, they shouldn't be drinking alcohol or caffeine. And what do a lot of people do on the weekends when they're out on a hot lake is that they're drinking either alcohol or soft drinks that have caffeine in them. And that's really sets them up for possible heat exhaustion. Of course, try to stay out of the sun. Be sure we're monitoring the vital signs, limit their activities, wear clothing that's suited, and all these things that we've already talked about. Need to monitor their labs because they can be some electrolyte changes. And like I said, the nausea and vomiting is usually related to the hyponatremia. So we don't want to let it get past this. We want it to stay at heat exhaustion, and then we make all these interventions and we cure them. Okay, then the heat stroke is your true medical emergency. This would get you in the emergent category. It has a very high mortality rate. If you catch it in the exhaustion phase, you have a very high chance of success. If not, they have high mortality rate. There's two different types of heat stroke, the exertional and the classic. Regardless, they are treated the same. So the concept of it is, if you have a heat stroke, it messes with your fluids and electrolytes, and you need to monitor your fluid and electrolytes, and you need to monitor body temperature, making sure that these things all get back into control because you've lost too much fluid, your body is too hot, and so you have set your body in unstable homeostasis status. So the exertional one is when they've been extraneous, and the classic one is where they've had chronic exposure to the sun. So what are we going to find? Well, with heat stroke, we're going to see an elevated body temperature greater than 104 degrees Fahrenheit or 40 degrees Celsius. So unlike heat exhaustion, heat stroke will show a high temperature greater than 104. You're going to see some mental status changes with a heat stroke, whereas you won't with heat exhaustion. Mental status changes is going to result as that high temperature affects the brain. You're going to see hypotension, tachycardia, tachypnea. Those three things are going to be all in line with dehydration, right? You're going to have low blood pressure, your heart rate's going to go up, you're going to breathe faster because you don't have enough blood, fluid, and volume to meet the oxygen needs of your body. The skin is going to be hot and dry, but some people may continue to perspire despite the fact that they normally won't, but some people may. This does not rule out a heat stroke if they are. It's all these other things that's going to rule it in that you need to assess for. So some of the complications that can come from heat stroke, of course, if you're not getting a good oxygen supply to your organs, they're going to have multiple organ dysfunctional syndrome. Your renal system is going to be impaired. You're going to have those electrolyte and acid-base disturbances. This will also affect the clotting factors in the body. It will pulmonary edema and cerebral edema, and that's a lot of why you have the confusion going on. So you want to be sure that you're watching for that. Your electrolyte imbalances, what you're watching for especially, is going to be sodium, potassium. You'll have hyponatremia and hyperkalemia. You'll have decreased in the renal impairment. You're going to see decreased urinary output. The organ system's not working correctly. Hard to tell a whole lot. With the pulmonary edema, of course, you're going to hear the crackles. So once we make sure that our patient has an open airway, of course, because we always have to do the ABCs, right? So they come in with heat stroke. We want to make sure they have an effective, an open airway, effective breathing, and of course circulation. Then we have to do rapid cooling for them. So we take off their clothes and we pack ice packs in their neck and around their axilla, the chest, or groin, or we can immerse them in cold water. Um, we can even drench them with large amounts of ice water uh, to try to get that core body temperature down. Um, And there is a box in there that tells you if you come upon someone the emergency care of a patient with heat stroke on chart 9.3 that you might want to look at, because it tells you what to do in the field and then what to do when you get them in the hospital. So these are things that you need to look for. If they start shivering during the cool down process, you want to stop that, because shivering is a warm up defense of the body. So you don't want that to happen. So you may have to give them some diazepam for that. When we get them to the hospital, because we've already took care of this pre-hospital setting, right? We give them oxygen, of course, because they have decreased fluid volume, they're having tachypnea, they're hypotensive, they need oxygen therapy. They need fluid therapy. We want to give them normal saline, 9% saline. Put in a Foley so we can measure that urine to monitor the renal function, and definitely get them cooled down. We can also give Thorazine 25 to 50 milligrams IM or IV for shivering, but your book recommends for them to have diazepam, benzodiazepine. So, and Thorazine falls in that category. If they start having a seizure, you can give them diazepam um, as well, or Valium. So what is the key difference in heat exhaustion? Well, for one thing, we're going to see some mental status changes, but the major one that I talked about was we were going to see an increase in that body temperature where we would not see it in the heat exhaustion. We can cool off heat exhaustion by rest and just putting them in a cool spot and placing cool compresses in certain areas. But in with heat stroke, it is an extreme emergency medical situation, and we have to get that core temperature down to prevent damage to the organs. All right, let's talk about snake bites. Everybody loves snakes. Your coral snake, your rattlesnake. Well, let's see. Yep, that's a rattlesnake. I don't know if that's yeah. And all kinds of snakes. That's a cottonmouth snake. That's what we have at my house. And then you have the copperhead. And so we have both copperheads and cottonmouths out in the area where I live, and that's usually the type of snake you see. And they're the two that are poisonous. And of course, a coral snake in the United States is poisonous when you have two yellow bands on the encompassing the red band. And as your book says, red on yellow, kill a fella, red on black, venom black. So if it was black with red, it would be okay. But when it's yellow encompassing the red, then they're poisonous. Me, I wouldn't stay there long enough to figure that out. I would be gone. So basically, your book is telling you just avoid snakes. Just avoid them. The best thing to do is if you see a snake, you go one way and they go another. I'm not going to really ask you to know the difference between a pit viper and the others. If you want to know that, you can look that up yourself. But mainly our pit vipers are the ones that are poisonous. So these are the grades of pit viper envenomation. If you have fang marks but you don't have any kind of reaction where they bit you, then no venom got into your system. They just bit you. If you have a little bit of swelling and pain, but you're not having any systemic reactions, then it's minimal. But then when you get to moderate, where you have the fang marks, the swelling beyond the side of the bite, then you start having nausea, vomiting, paresthesias, and hypotension, then that's moderate. And then severe is when you have all of that other plus subcutaneous ecchymosis, severe symptoms, and then having coagulopathy, which is basically uh, the worst part of having a snake bite, especially with a pit viper. They do have the coagulopathy is the main symptom that you are trying to prevent from happening when you do have a snake bite. So, what are we going to do if we get bit by a snake? All right, so let's talk about what the effects of the venom is. Um, the goal of the venom for the snake is it wants to immobilize its prey, kill its prey, and it also helps to digest its prey. So because of the goal of the venom for the snake, if a snake bites one of us, it breaks down our tissue, it alters membrane integrity, and it impairs clotting. So the things that it's going to do is we're going to see some local tissue necrosis, some massive tissue swelling. We're going to see intravascular fluid shifts. We may see some hypovolemic shock, pulmonary edema, renal failure, all the way to hemorrhagic complications from disseminating intravascular coagulopathy. So we want to be sure that we are um, monitoring anyone that comes in with a snake bite, because these are the things that we're going to see happen. And it's going to happen usually in that order. So, hopefully we can figure out how much venom's been injected. Um, assessing the bite and the area around the bite, as the table showed us earlier. We've got puncture wounds. We're going to see, how much swelling is in that area. Sometimes vesicles may form. Uh, the patient may get a metallic taste in his mouth, and he may have some tingling in the face and the scalp. Start having muscle twitching, nausea and vomiting, seizures, and clotting abnormalities. Hopefully we don't get that far, but sometimes snake bites can be very severe. So the first thing we need to do is to move the person that got bit into a safe area away from the snake. Now the chances of the snake biting you and hanging around is pretty slim, but you want to get you don't want the person to get bit again. Snakes have the pit vipers especially have rolls of fangs. And their two largest fangs are in the front, and then they have smaller fangs in the back to replace the ones in the front when they get broken or used up. So you want to get them away from the snake. You don't want them to be crying or screaming or jumping around, because you want to discourage circulation. That's why you encourage rest. Take off all jewelry or constrictive clothing, because if you start having swelling, you're not going to be able to remove the jewelry, and it's going to cause a problem with your circulation. You want to immobilize that extremity in a position of function, because you're going to have some issues with the swelling, and you want to be sure that you immobilize it to help limit the spread of the venom so that it's not moving around. You want to keep that extremity below the level of the heart to decrease the circulation. Again, try to keep the individual warm and calm, and don't give them any stimulant such as caffeine. Don't give them any alcohol. It only will cause the venom to spread through vasodilation. So you don't want to give them any alcohol as well. The caffeine will cause vasoconstrictors, but it will also cause a stimulant, and you don't want to do that. So, um, if we're not going to be able to get them to the hospital within a certain period of time, within a few hours, we need to apply a 2 to 3 centimeter constricting band that is not used as a tourniquet. What your book recommends is an elastic bandage wrapped around the area. So it's really tourniquet. If you put a tourniquet on, you could cause loss of limb. If you don't put a tourniquet on, the venom can spread. So it's kind of like danged if you do and danged if you don't. You want to assess that distal circulation to the bite frequently. And of course, please do not incise and suck or apply ice to the wound. If you incise and suck, you may get the venom. If you apply ice to the wound, it can cause worsen your patient's outcome by applying ice to it. You apply ice to spider bites, and your book don't recommend that you kill the snake and bring it into the ER anymore. Since everybody has digital cameras these days, they would prefer you take a picture and send it in. This is an extractor that if you are highly likely to get bit by a snake or going to be going into areas where there's lots of snakes, you can go and look at this. It's actually quite fascinating, and it does remove venom from the bite. So please take a look. All right, once we get them into the hospital, first thing we want to do is put some oxygen on them. We'd like to have 2 IVs if we possibly can. And we would prefer to have the crystalloids here again, normal saline or lactated ringers. We want them on cardiac monitor so we can monitor their blood pressure, oxygen, and cardiac functions. The bites are usually painful, so we want to be sure that we have opioids to give for the pain. They should receive a tetanus shot if they've not had one in the last 5 years because of the puncture wound. And of course, we're going to have to do wound care. We may even have to be doing some debridement. We're going to go ahead and give them broad spectrum antibiotics. And of course, we want to get some baseline labs and a coagulation profile. The PT, PTT, and INR. All those should be done. If you don't know what I'm talking about, you need to look that up in your lab book. Because we really need to know, have a baseline to see what we're looking at. So, we do have antivenom that we can give. Um, Antivenom is made from horse serum. It can cause serum sickness. It's a type 2 hypersensitivity that doesn't develop, can wait till up to 21 days before it develops. Usually starts out with a rash, then we'll have fever, pain, pruritus, sometimes hives. We usually rarely see an anaphylactic shock from antivenom. You want to always perform skin testing before you administrate it. Antivenom is not been given as much. Uh, Crofab is one that is given more often than the one than the older antivenoms. The Crofab is made from sheep instead of horses, and we don't see serum sickness occurring quite often with Crofab, and we don't have to do skin testing. We really would like to be able to give as soon as possible, the optimal timing within 6 hours. So we want to give it within 6 hours of the time of the bite for it to actually work well. We usually give 4 to 6 vials over an hour, and then we can give 4 to 6 vials more as well. And then hopefully we get our symptoms under control. We can give 2 vials every 6 hours for a total of 18 hours. I don't expect you to actually remember 4 to 6 hours, over an hour, an additional 4 to 6 may be given, but you do need to know that it needs to be given within 6 hours. And it is, you know, highly effective. Um, and the worst thing that's going to happen with the snake bite is the coagulopathy, developing DIC. And so that's why we want to keep an eye on the lab to make sure that we're not having any bleeding um, with snake bite. Because if we have clotting, if we have miniature clots, that what usually happens is we have those little clots that form, and then our clotting factors all go away, and then we develop the DIC, and that's a very life-threatening situation. Coral snakes. Coral snakes are a little bit different. They are very extremely potent and can be deadly. They have two toxins that affect the muscle and the nerve. And the saying is, of course, yellow, black on yellow, kill a fella. Red on black, venom black. So patients experience usually once they get, if they're bitten in the lower extremities, they'll have ascending paralysis. They're going to have a decreased pain perception. They may have respiratory paralysis because of the muscle paralysis. They have mild pain at the site with very minimum swelling because it doesn't work on tissue. You may not even be able to see the fang marks of the snake. You don't see clotting changes. Toxin effects may be delayed from that. So basically, what you're going to see is nausea and vomiting, headache, abdominal pain, paresthesia, mental status change, cranial and peripheral nerve deficits. These are all muscle and nerve issues. It doesn't have anything to do with the clotting. So the pit vipers, the difference between the pit vipers and the corals, the biggest thing is how the venom works in their body. The venom works in our body first localized and then systemic with coagulopathy in the pit vipers, and then in the corals it is going to work mainly on our muscles with paralysis, and it's going to work on our nerves with the paresthesis and difficulty speaking and nerve deficits. So these are things we watch for. If we can, let's take a picture of the snake so we know if it's a poisonous snake or not. You don't apply a band on this snake bite because there's no tissue necrosis. You can put an elastic bandage on so that the lymphatic flow is slowed, but you don't impede the arterial circulation. So we want to get them to the hospital as soon as we can. Vital signs, airway. We do antivenom even if we don't know if there's been a venomation, because there's no way to tell, and it's a lot better to be safe than sorry. So they don't produce antivenom for coral snake bites anymore, but there's a lot of quantity still available. However, there's a high risk for anaphylaxis, and you have to give 3 to 6 vials over 2 hours. So don't get bit. Don't keep venomous snakes as pets. Don't keep any snakes as pets as far as I'm concerned. Wear your shoes when you go outside, especially those of us who live in the country. Well, we know there's snakes out there under those rocks and leaves, and when it's hot, they like to get out in the cool, and when it's cool, they like to get out and lay in the sun. Use caution. Be sure you're making enough noise you run those snakes off. Be sure you're wearing good, heavy boots. Don't harass your snakes. Don't play with a dead snake. It can still bite you 20 to 60 minutes after death. I watched a YouTube video where somebody cut the snake's head off and laid the snake's head beside the snake's body, and the body was still writhing around, and it moved around, and the snake's head bit itself. So they definitely can still bite you. So if you do have the snake, put it in a sealed container if you're going to take it to the medical facility. Ooh, brown recluse spiders. We all hate these things, and they all like to be in damp, dark spots in your home, back in the deepest closet, in your favorite pair of shoes you only wear once or twice a year. So these are things that we really have to watch over. They always result in skin ulcers. So, may or may not feel the thing bite you at the time it bites. You may or may not see what bit you. It's going to itch. Then it may start as a little vesicle that's red, and the swelling worsens, and then eventually the center of it will turn bluish purple, become necrotic. Eschar is going to form, which is just necrotic leathery covering over the wound. And then with a combination of all these signs, it's referred to the red, white, and blue zone. But this can take, once this lesion is formed or wound is formed, it may not heal. So they may actually develop into a systemic infection. And so we may end up having to do IV antibiotics. They usually develop MRSA from spider bites. Um, so some of the things that we're going to see in the worst case scenario is going to be hemolytic reactions, renal failure, and death can occur from these if the treatment's not done as it should be. And again, you don't really know that it's a brown recluse spider bite until it makes this bluish purple center and becomes necrotic. So you'll have debridement. They recommend have tetanus shots. These are the fangs, up close and personal. I could have lived without that, couldn't y'all? This is a recluse spider bite. See, this is down to the bone. This is a recluse spider bite. So they can be very detrimental to your health. So first of all, we're going to use ice intermittently during the first 4 days after the bite. And the reason we do it the first 4 days after the bite is because the venom is still actually able to move and progress in the wound. So we want to do that until there is actually no progression in the size of the wound. It's going to decrease the enzyme action of the venom, and it's going to limit tissue swelling and necrosis. Never ever use heat because it will cause the necrosis to increase. Elevate the affected extremity, just the opposite of a snake bite. Provide your local wound care if you got any type of antibiotic or anything to put over it, and then rest the extremity. Try to be sure that they're not up jumping around on it. Once we get them to the hospital, we're going to again dress their wound, possibly give them some antibiotics, some medication that we can actually give them, which is not in your book, is the Dapsone, 50 milligrams PO BID. And of course, again, because it's a puncture wound, deep wound, a tetanus injection. And then, of course, we may have to do reconstructive surgery after the wound debridement, after you've seen those wounds. So, those are things that we want to watch for. Then we have the wonderful black widow spider. Her envenomation produces lactodectism, severe abdominal pain, muscle rigidity, spasm, hypertension, nausea, and vomiting, facial edema, ptosis, diaphoresis. Man, she's just really a bad person all the way around. So there's lactodectism is when the venom causes neurotransmitter release from nerve terminals. So sometimes you don't know that you've been bit by a black widow spider. Usually, if you're going to have any symptoms from it, it usually develops within 1 hour. and of course involves all of these. Again, apply an ice pack. Um, and the reason being for the ice pack is the same as it was for the other, except for there's not going to be any necrosis there. Um, so you don't have to worry about um, necrosis at the tissue site because it's doesn't uh, affect the tissue as much as it does the neural system. Um, Muscle spasms and eyelid drooping and painful tingling or numbness. Usually the area itself is self-limited and resolves in a few days. So the cold application of the ice pack is supposed to decrease the action of the neurotoxin. So be sure we're watching for that systemic toxicity. Support the patient's airway, breathing, and circulation. Of course, that's always the main thing, and then take the patient to the hospital, where we're going to give them muscle relaxants for those spasms, calcium gluconate for spasms, opioids for their pain. Again, a tetanus shot. They're going to become hypertensive, so we're going to have to give them antihypertension, and of course, be sure that we're watching for pulmonary edema and shock. Tarantulas, we all see these crossing the roads all the time. They usually only have local effects. We definitely want to get all their hair off where they bite you if you got tarantula hair because it does carry MRSA. And again, tetanus shot. Scorpion stings are usually self-limiting. Uh, Best treated by just taking something for pain and taking care of the wound. There is one species that is potentially fatal, and it's that one right there. Hopefully we never see it. So we should do the ice pack to the sting site because we want to control pain. Be sure we're watching for symptom progression just in case it was the one that's potentially fatal. If we have a fever, let's treat it. Again, the tetanus prophylactic, and of course our wound care. Bees and wasps. Some of us are highly allergic to bees and wasps. We should always carry an EpiPen. You should run away, but never get in the water because they'll just hang around until you pop up, and then they'll attack you when you hop up. So just run as fast as you can. I got into a bumblebee nest. Those are big old bumblebees, and it was behind my dad's house, and they had a well house. And I walked by the well house. I had on some perfume, and the next thing I know, there was like 6 bumblebees in my shirt all over me. I was running, and you don't think I wasn't naked by the time I got in the house away from those bumblebees. You are sadly mistaken because I came out of those clothes because they were in my clothes. And luckily, the bumblebees weren't as bad as the wasp. I'm highly allergic to wasps. There's always a potential for anaphylactic shock, and there's a potential for toxic effects if you have multiple stings. You know, you've heard of packs of bees attacking people and them dying. There is toxic effects for that. Try to make sure that you remove the stinger and apply an ice pack. In the past, we've always taught to remove the stinger with a credit card because we always thought that removing it with tweezers would cause the little sac of venom, especially on these, would cause it to squeeze more venom into the wound. But your new research has shown that this is not true, and tweezers are effective at removing your stingers. So, hopefully, if you know you have a reaction to bees or wasps, you should keep Benadryl at home. Benadryl is your first line of defense if it's when you first get stung. If you only have swelling at the site. You know, I got stung on my little finger, and my armpit was swollen. My whole arm up to my armpit looked like it was going to pop the first time I got stung by a wasp. And I got liquid Benadryl. I got Benadryl for that. People who are highly allergic that have had episodes of tightness in their chest or trouble breathing should always have an EpiPen. Your EpiPens um, are very easy to use. Um, they are pre-measured in how much dosage you should give, and they're given IM when you give them at home. You can give them, you should give them every 15 minutes until um, the patient is in the hospital setting, and then they can take over, because usually the epinephrine only lasts for about 15 minutes, and someone who's highly allergic will only keep them. It's not what it's doing is that it's decreasing the inflammatory response. It's not getting rid of the venom. So the B venom's still there, and once the epinephrine wears off, then you have the venom is still there, causing another inflammatory response. So you need to be sure that you're giving it and watching um, your patient closely. Call 911. Make sure you're in the hospital, and usually when they give epinephrine in the hospital, they'll start it and usually give it by IV so that it's continuous, maybe. Um, or maybe not. Maybe just give it until the symptoms are down. Be sure they've got oxygen. They're monitoring the airway, so they want to make sure that they have a patent airway. They're going to give steroids, whatever they have to do for the next several hours or days until that venom gets out of their system. So prevention is the key. Stay away from bees and wasps. Stay away from areas you know where bees and wasps are going to be. Be sure you're carrying your EpiPen. You always want to make sure that you've got your EpiPen with you. And try to stay away from those things. I don't expect you to know the difference between the dosage of dilution of Epi when you're given IM versus IV. Um, I should have taken that off of my chart, and I meant to, but I didn't. Because this particular um, edition of the book doesn't really ask you about epinephrine, and you're going to learn more about that later. So here's what your EpiPen kind of looks like, and it has 0.3 milligrams in it. And right here is the dosage for, it's 1 in 1,000 for adults, and it's 1 to 10,000 for neonates. So you always want to make sure, you know, what you're giving. So one single dose is going to give you 0.3 milliliters or 0.3 milligrams. Whereas when you have to dilute this down for IVs, you would make sure that, you know, 0.3, if you've got 1 milligram to our 1 to 1,000 ratio, you're going to have to know how to figure that one out. Okay, so 0.3 milligrams would be how many? 0.3 would be 300. So, all right, lightning injuries. Lightning does strike twice. The rescuer is not in any danger if a person gets struck by lightning and they go over to remove the patient out of the storm. Lightning affects cardiopulmonary and the CNS. So the most lethal thing is going to be that the lightning strike causes the heart to go into asystole. And of course, the immediate thing you should do is chest compressions. So lab work that might be abnormal on somebody that has a lightning strike would be that we're going to see some muscle destruction. So we may see some changes in your EKG, we're going to see some changes in your creatinine kinase level, your CK, because you will have some muscle damage from that. Sometimes rhabdomyolysis can occur because of that and cause renal failure. Ooh, cold. I usually talk about this in burns, but since it's here, so let's go ahead and talk about frostbite. And I put this little question up here for you because I would love for y'all to see if you can Google it and see exactly what it means that cotton kills. Actually, what it does mean, I know I can hear all of you now. I don't want to look at that, but I don't have an clue. What it means when cotton kills. Cotton is one of the worst fabrics you can wear in the cold. It holds moisture, and it can cause it causes more cold than if you wore wool. So something that you really want to make sure patients who are in cold areas that they wear things that are warm, such as wool, and they dress in layers. So you should avoid all cotton and stick to wool and cover everything and have layers so that your inner layers stay dry if you happen to get wet. The outer layer should have waterproof, breathable fabric. And of course, you should always wear a hat because we lose a lot of heat through our head, and we should also wear a face mask. So basically, that's what it means by cotton kills. If you go outside in just your cotton gown in sub-zero weather, you're going to die. Okay, so what are some risk factors for hypothermia? Well, some of the risk factors that can promote hypothermia would be cold water immersion. Probably all those times I jumped in the river and like froze. Sepsis, trauma injuries, shock, immobilization, especially cold weather for people who work outdoors and the homeless. Advanced age, even when what we think is warm, an advanced age can suffer hypothermia. Some types of medication, alcohol intoxication, malnutrition, inadequate clothing, of course. An environment temperature that's below 82 degrees can produce impaired thermal regulation in a susceptible person. The elderly are at risk year-round in most parts of the world. So we really need to monitor our elderly um, quite often. Hypothermia is also increases, their increased loss is if they manage to get wet. So we want to be sure that we are taking care of it. Mild hypothermia, um, we just need to shelter them from the cold environment, take off their wet clothes, undergo passive or active external warming such as applying blankets or clothing. So we want to do that. If we use a heating blanket, we have to monitor for possibilities of burn injuries. Usually, if we have our victim drink warm, high carbonated water, liquids that don't contain alcohol, we actually can do better with that. The moderate and severe, you should be taking them to the hospitals. Um, we want to prevent ventricular fibrillation. We want to position them in a supine position um, to prevent orthostatic changes in blood pressure from that cardiovascular instability. And then we may actually see something called after drop. So some mild will present itself, shivering, mental slowness, these particular things. Then this is what we need to do for the treatment, which I just talked about. We're going to see motor impairment. They're going to be confused. They're not going to be able to shiver because they no longer have that. Dysrhythmias are really common in this. And then they have clotting abnormalities. So we want to put them on that cardiac monitor to monitor their heart and handle them gently. We put them again on that horizontal position in the spine position, maintain those ABCs. That core body temperature should be up to 86. We may not be able to defibrillate them until we get their body temperature to at least 86. After drop is the continued decrease in core body temperature after the victim's removed from the cold environment. It's caused by the return of the cold blood that's in the peripheral area to the central circulation. And we should warm the patient's trunk first and then warm the extremity. So we should get warm IV fluids, heated oxygen. We might even can do heated peritoneal bladder lavage. So people that are severely hypothermic are high risk for cardiac arrest. So avoid using external rewarming with heating devices. It's contraindicated because of the rapid vasodilation that external heat has. So, treatment of choice is cardiopulmonary bypass, and this is like the ECMO down at Children's where the blood is bypassed and warmed through a warmer. So, a long-standing principle in treatment of patients with hypothermic cardiac arrest is that no one is dead until they are warm and dead, which means that there are a number of survivors who suffered a prolonged hypothermic cardiac arrest. So your patient is not actually going to be able to be resuscitated until they are warmed up. So unless they're warm and dead, they're not dead. Frostbite looks like this, and it's bad stuff. And you can get frostbite before you realize it. First you think your feet are cold, and then you think your feet aren't cold, and then you're in trouble. Or hands. So frostbite is when the body tissue freezes. And it's like a burn. It can be first, second, third degree, fourth degree burns. And frostnip is just superficial cold injury that you feel pain, numbness, and pallor of the area, but you can relieve it by applying warmth. You don't see any tissue damage with frostnip. Frostbite, of course, is worse than a nip. The first degree frostbite, usually you're going to see hyperemia, which is increased blood flow of the involved area, and edema. Then you're going to see blisters when it gets worse, second degree. Third degree, you're going to see blisters with dark fluid in body parts that is cool, numb, blue, or red. And then fourth degree, you don't see any blisters, you don't see any edema, numb, cold, bloodless, and you're going to set up gangrene and lose that body part. Most likely going to be amputated. So the first thing we do, treat it, recognize it, try to we want to do rapid rewarming with frostbite. They used to tell you not to do rapid warming, but now they're telling you it needs to be rapidly warmed. Frostbite's easily managed using body heat if it's just superficial. But if it gets past that first degree, it's a lot worse. Give them pain medicine. Don't rub on the area. You do not want to apply heat or massage them because it produces further tissue injury when the frostbitten areas are past that first level. That full thickness, fourth degree, third and fourth degrees are really, they should have rapid rewarming in a warm bath of water, not dry heat. So, even after it's warmed up, you need to handle um, them carefully, and the patient should have a tetanus shot because of that. Always monitor your circulation in that frostbite. Some people get altitude related sickness. Those of you who've been to high elevations probably realize that that can happen. It can cause a physiological response in the body that can actually be fatal. Um, Most people can acclimate to it. People who are born in those areas are actually born acclimated to it, or acclimated to it. Uh, we have acute mountain sickness, we have high altitude cerebral edema, and we have high altitude pulmonary edema. Um, so you really want to make sure that people realize where they're going and what's happening. And what's really odd to me is that the oral drug acetazolamide is used to prevent and treat AMS, and it's a carbonic anhydrase inhibitor, um, and it causes a bicarbonate diuresis, which rids the body of excess fluid and induces metabolic acidosis. The drug should be taken 24 hours before ascent. And of course, dexamethasone is a drug that they use for AMS as well. And HACE and HAP are can be treated by sildenafil or tadalafil, which are both treatments for erections or failure to erect because of their pulmonary vasodilator effect. So it's really pretty interesting that we use some drugs for that. And they actually even use sulfa drug. Well, actually, the acetazolamide is a sulfa drug, so you want to make sure that they're not allergic to sulfa before you give that drug. If you start feeling sick at a high altitude, get to a lower altitude. Take those medications we talked about. Early recognition is essential. If you don't recognize that you're having difficulty breathing, you're having nausea and vomiting, and having AMS, then it's going to progress on to the more potent diseases. There's a treatment chart in here, chart 9.8 that y'all can look at. Near drowning is no longer a term that's used. So be sure that, you may see near drowning or you may see drowning that survived. So it's the same thing. They've just decided that near drowning is not an adequate description of what actually happened because the patient actually did drown, but they were resuscitated back. So, of course, prevention is the key. You don't want them to be going to swim by themselves. And little kids are bad at that. They want to go swimming. They don't really care if there's anybody with them or not. So you really have to make sure that bodies of water, like pools and things, that children can't get to those. The type of water aspirated makes a lot of difference in the pathophysiology of the drowning, whether it's salt water or fresh water, or because both wash out the surfactant of the VOI, and we all know that surfactant is a wonderful thing. The salt water is going to create an osmotic gradient. Warm water, they can drown in quicker than cold water because cold water has a protective effect. We can usually see hypothermia offering some protection to the hypoxic brain. Because it reduces cerebral metabolic rate. The diving reflex, if the hypothermia exists, handle carefully to prevent that diving reflex because it's going to be a physiological response to the asphyxia. We also need to make sure we know why they drown. You know, if they had a spinal injury or if they got knocked out, we want to make sure that we're doing what we should be doing. Of course, our priority is safe removal from the water. We want to make sure that that not only do we get them safely out, but we don't want to put ourselves at risk. And of course, if hypothermia exists, remember hypothermia causes cardiac arrhythmias. So remember we talked about we should handle them carefully. So they should be handled carefully in order to prevent ventricular fibrillation. So if hypothermia exists, handle carefully to prevent the ventricular fibrillation. Okay? And that goes back to what we learned about hypothermia. Now let's get on with shock. Shock occurs when you have a need for oxygen that's not being met. So it's actually the lack of oxygenation and tissue perfusion that would maintain body function. Shock is a result of something, either a hypovolemia, infection, dehydration. It is not in itself a disease. It is basically a condition. So anything, any condition that's going to impair our delivery of oxygen is going to start the syndrome of shock. And shock always leads to a life-threatening emergency if we do not catch it in time. In fact, it can lead to death if we don't recognize it. And this is one of the main issues that Keith R.N. talks about in his dead patient walking video. If you haven't watched it, this is one that he really talks about. It's a patient that came in with urinary tract infection, and it went from urinary tract infection to sepsis to septic shock to death. And it was all because the signs and symptoms were not recognized that this patient was in shock from the systemic infection. It's classified by the impairment it causes or by what causes it. So there's several classifications of shock y'all will need to know. So these are the types of shock that we're going to talk about. And I'm going to put up some case studies for you guys to look at and work over to see if you can tell the difference between the different types of shock. Most shock is always treated basically the same, and we're going to talk about that as we go through. You should know how oxygenation and tissue perfusion occurs. You know, and it all depends on, it's all related to your mean arterial pressure, MAP. And that is the things that influence the mean arterial pressure is blood pressure, or actually total blood volume, cardiac output, and the size and integrity of the vascular bed. So those three things are directly related to MAP. So increases either in the total blood volume or cardiac output is going to raise your mean arterial pressure, and then a decrease in them is going to lower. So remember, increase raises, decreases lowers of the total blood volume or cardiac output. Those are just things you really need to look over and check the pathophysiology if you don't remember how oxygen tissue perfusion occurs. So, hypovolemic shock is one of our biggest shocks that we see, and we're usually prepared for a hypovolemic shock. This is when too little blood is circulating, whether it's from the loss of blood, whether it's from dehydration, regardless, whatever it is that decreases that blood volume. Cardiogenic is when we have pump failure. This is kind of like when your fuel pump quits working in your car. It's just not going to go any further. Distributive is when your blood volume is displaced for some reason. And then obstructive is when the heart's normal and working okay, but something else is causing it not to pump effectively. And we're going to look at each one of these individually. So, hypovolemic shock. We have our stages listed on page 37.1, so make sure you look at your stages of shock and types of shock. Actually, 37.1 is the actual different types of shock that are placed in a little box so that you can actually read them. But the main thing I'd really like for you to look overall view before we go into actually hypovolemic shock is just that chart on 37.1, which has the key features of shock. These are things you're going to see in any type of shock. They all have this in common. So if you know the basic concepts of shock, regardless of what type it is, you should be able to tell there's some type of shock going on by these particular features. You're going to have decreased cardiac output, which is going to result in increased pulse rate, a thready pulse, decreased blood pressure, narrow pulse pressure, postural hypotension, increased respiratory rate, increased PaCO2, decreased PaO2, cyanosis, all these things that you should be watching for in any of your patient that might be at risk or not, because they can be at risk before you even know it. So you want to be sure that you look at that key features to know the overall signs and symptoms to look for any type of shock. And then we're going to talk about each individual type of shock, such as the hypovolemic shock. There are 4 stages of hypovolemic shock, and they are listed at table 37.2. There's the initial stage, the non-progressive stage, which is also known as the compensatory, the progressive stage, and the refractory stage. So in the initial stage, we have really good response if we catch it there. Even in the compensatory stage, if we catch it there, we can have a really good response and outcome. Once we get to the progressive stage and the refractory stage, we are in trouble. And if we go from progressive to refractory stage, our patient's going to die because we have multi-organ dysfunction syndrome occurring, and our kid's going to die. So what causes hypovolemic shock? It's a loss of blood volume from the vascular space, and it's going to result in that decreased MAP that we talked about. We're also going to have a loss of oxygen carrying capacity. Our blood flow is going to decrease. We're going to have decreased tissue perfusion. All these things are going on, and the main trigger that's going to lead us to that hypovolemic shock is that sustained decrease in MAP from the decreased circulating blood volume. We do have compensatory measures that sometimes, our body kicks in and we don't really catch um, this in the early stage because of that. So, our role is to make sure that we're assessing for worsening or improving conditions. We're maintaining airway. We maintain a good IV. We have oxygen. If our patient is hemorrhaging, we need to control our bleeding. We need to stay with our patient and administer whatever medications that we need to administer, usually vasoconstrictors, to try to keep us from having issues with the hypovolemic shock. Sepsis and septic shock are a type of distributive shock. It usually begins as a fungal or bacterial infection, and we are going to see that progressing to a dangerous condition over a period of time, such as the UTI that I talked about. Figures 37.3 on page 749 is a good chart to look at to see how septic shock begins. It starts with a local infection and goes on. The picture of the catheter here is that, we put catheters in everybody that has surgery just about, and if they're not removed in a timely manner, they can actually result in a UTI, which results in septic shock. And there are certain ages that are more likely to develop shock than others are. Septic shock has a lot of inappropriate clotting with it, and that's one of the things you're going to see with septic shock is SIRS, which is systemic inflammatory response syndrome. It's going to start causing micro clotting, which is going to result in DIC, disseminated intravascular coagulation. So you definitely don't want that to go on. Sepsis is the beginning, and it's the presence of the infection systemic wise, and then when they become septic shock, or when they get into severe sepsis and it goes into septic shock, which is sepsis induced hypotension that's persisting in spite of being adequately fluid resuscitated. This is the stage we're going to see MODS, multiple organ dysfunction syndrome. At this with this, but when they actually get into septic shock, when we don't catch all the things that we should be, we are going to see a high rate of death. So, infection is usually confined to that one area. It could be infection of the toe, like we're showing right here. You have your inflammatory response where you have swelling, you have increased blood flow down there. The edema is a good thing because it's got all those white blood cells and things going on that are macrophages that are taking care of the infection. So that's really a good thing at this particular time. And then, of course, the infection escapes. Then we start seeing hypotension, orthostatic hypotension. They may or may not have a temperature, depending on what the immune function is. And we've already talked about the microthrombi and SIRS. So the severe sepsis is we're going to start seeing that DIC, hyperglycemia, cardiac outputs increased, and that usually doesn't make a whole lot of sense that it is, but it's in a hyperdynamic state at this time, and the pooling of all that blood from the capillary leak and the microclotting and the DIC developing actually stimulates the heart, and cardiac output is increased because there's a more rapid heart rate and an elevated systolic blood pressure. That patient actually looks like they're doing better, but they're not. So you don't want to be fooled at this time. Once they reach in this stage, and the downhill course is really rapid. White blood cells may no longer be elevated. Why? Because we've used them all up and the neutrophils cannot be produced fast enough. So we see a low neutrophil count. We have a low O2 sat. We have increased respiratory rate, decreased or absent urinary output, and change in level of consciousness. Urinary output is very telling in shock of all types. Okay, 60% is the rate of death in septic shock. So what should we do? First of all, we got to make sure we know what we're looking for. So we got to be sure that we're assessing for early signs of sepsis. Most hospitals have a sepsis bundle, so be sure you know what that is. And this is just a bundle that they do to monitor for sepsis, how to treat sepsis, how to prevent sepsis. Oxygen, of course, medications, and blood replacement therapy are all things that we're going to be looking at. Be sure that you look at the drugs that we use for hypovolemic shock, which I failed. I meant to make sure we covered, but I failed to mention it. Well, I did mention the vasoconstrictors, but we use the vasoconstrictors, know the adverse drug effects, toxicity, know how they work, and the agents that enhance myocardial perfusion. Be sure you know those, look at those drugs and what to monitor for and what some of the side effects are. Blood replacement therapy is also something we're going to see with septic shock, because with the DIC we're losing blood, so we may be seeing some plasma and platelets being replaced to try to help with coagulation. Age is a very big thing to be sure that we're watching for sepsis in older patients who are especially those that are immunosuppressed. So we do have risk factors for shock. That's down chart 37.5. Be sure you look at that. And then we have community-based care, which is chart 37. Oh, and there's a chart for bundles, or table for your bundles for resuscitation and management of severe sepsis that you might want to take a look at to know what the bundles are. If I were you, I would go through and answer those questions that you're seeing on community-based care, or on that you see in the little boxes. That will help you with your test to go through and look at those. So with community-based care, we want to make sure that, of course, the sepsis is resolved before they're discharged from the acute care setting. But because a lot of patients are being discharged early, they can develop sepsis after they've been discharged and returned home. So we really want to make sure that these patients that are at risk, that we are assessing them and make sure that we teach them what they need to know for taking care of themselves at home. They need to know, to take their temperature at least daily, to watch for make sure they've got good urinary output. Make sure we teach them about hand washing, eating well, skin care. Teach them, to the signs and symptoms of infection that may occur. If you are, the chart 37.6 up there, home care assessment, not only tells you what to tell the patients to do, but this is if you did a home visit. And what you should assess your patient for. Some patients are discharged home and then they set up home health to come visit them. And these are things that you should assess for if you are checking for signs and symptoms of sepsis. So there will be quite a bit, there will be quite a few things about shock and how to tell what shock is what, and then your ER and your ER triage. So my test, or my portion of the exam, is 40%, and Miss Candler's is 60. So I will have 40 questions, and she will have 60. So hope you have had fun studying about ER, and I know you're going to have fun going to ER. If not fun, you will at least have an excellent learning experience. I know you will. So just jump in there and do what you need to do, and do things that you never dreamed you could do.